All right, so welcome, and we're going to talk today on hypermineralized posterior teeth. What I've done is I've taken these slides from the presentations that I do in the full day course, but we can talk a little bit more in depth about these ones. So traditionally, posterior teeth are traditionally treated with fluoride. And it has been known, we've been always putting fluoride on them of different kinds, and the modern kinds of fluorides that we've been using have given us very little benefit. We do the best we can. We've used tooth mousses and everything like that, sort of going, yeah, this should do it. But I don't know whether you have found in the cases that you've been treating, but I have found that there's been very little benefit with that. And then we put the GIC protectant on there as a temporary filling kind of approach. And the whole thing is designed about trying to block the thermoconduction and the sensitivity and nature of these very, very difficult to treat teeth. Oftentimes when we're using LA, we have very ineffective local anesthetic, and we've all had that. And it's really difficult because you're trying to do the best and you're just not gaining any ground. And then we have the stainless steel crown sedation or GA and extraction. So when I started using silver fluorides for treating hypermineralized teeth, it revolutionized what we were doing in the treatment of these. And it made it so much better, not just for the patient, but also for me, because I was able to descale the level of anxiety that my hypermineralized patients were experiencing every time they went to the dentist. Because what they were doing is they were having this heightened level of anxiety based on the fact that they had had a checkup and somebody blew air on their teeth. So they were putting the fact that they were having a checkup together with dental pain, and we've been able to sort of bring that down on them. So what I would like to look, and I love this photograph that Jeremy Horst has given us, because this is basically what you have to remember when you are treating a hypermineralized tooth, when you're treating any decayed tooth, but when you've got dentine and enamel that is not formed properly. It's hypomineralized, so it's devoid of minerals, so it's not hard, it's more porous. You can actually, I believe what you're doing is you're actually filling that missing part of the enamel substrate with other material, and that's why we're getting such incredible desensitization. I actually was talking to Jeremy Horst about this on Monday, and I asked him about this particular photograph and where he got it from and how he came about. So you're going to have to listen to the podcast on that, because it was very, very cool. I won't go into details there, but what I want you to do is I want you to remember this photograph whenever we're talking about the hypermineralized teeth as well. Okay, so this is the case of a little fellow. He was a 12-year-old boy. The first time I had seen him, he had come to the practice. He was highly anxious. Obviously, he had a fear of pain and needles, didn't want to go near them. And he had a previous history of GIC had been placed in this particular tooth, and it had come out all the time. So the first thing that we wanted to deal with is we wanted to reduce his sensitivity, because he was not cleaning around that tooth very well, because it was too painful. And then so we decided, you know, the obvious thing would be, oh, like refer him to the orthodontist and everything like that, but that's not going to fix the here and now. That's not going to fix what we needed to do to deal with this tooth right now. And so we discussed options of, you know, all of the normal sort of things, but I did then broach the subject of using the CSDS in the ARMOR approach, so that there was a framework around what we were going to be doing. And they chose that because I was able to do that without putting any local anesthetic, so that suited him. And I didn't even have to blow air on the tooth for the very first visit. So what I did with this tooth is I just basically dried it with a cotton roll or a cotton pellet, and just dried all the way around here and got that dabbled dry basically. And then I put the CSDS, I put the 3 minutes of the silver fluoride on there, and then we put the stannous fluoride, and I covered it with Durafat. And then I said I'd see him in a week. When he came back the following week, this is what we saw. So the sensitivity had reduced incredibly. He was now able to eat on that tooth. It was still a little bit sensitive, but nothing near what it was the first time round. So I find that the hypomineralized teeth definitely need a second application I like to get rid of all the sensitivity. So this time though, he allowed me to puff air on the tooth. So I was able to get a really big, a good decent puff of air on there. And then that was helpful then to have an increased uptake of the silver and the fluoride into that tooth. So that was visit 2, okay. And when he came back, the third visit, this is what we saw. Now, what I want you to sort of realize is that as you're going along with these photographs, they're getting clearer and clearer. And that is because the level of anxiety of the kids is dropping. And so you can actually get, a much better photograph with an intraoral camera, because they're not, living on the edge thinking it's going to hurt. So that you'll see that this is a much better one than the one was before. And so then when I got this particular tooth back for this fellow on the third visit, there was no sensitivity. Okay, so we had put silver fluoride like all over this tooth, not just around here, but only the parts of the tooth that had been affected by demineralization or caries had actually stained. So you can see that there was some staining around here, and this was dark. And this is where there was an element of the enamel had actually broken down, and there was some caries activity. It wasn't huge in there. And what I did that time is I got a slow speed burr, and I just sort of took some of that dark stuff off. It didn't go deep by any means. I just made it so it got hard down into the, and we established that beautiful crydentin air. And then we went and we put what I call here a restorative, I wouldn't have called it a restoration, I called it a restorative sealant, because basically what we were doing is we were sealing over all that area around there. It was not deep. I didn't actually take tooth tissue out to make a preparation. So I just put the dentine conditioner, Equiafort, and I did put Durafat over the top of that, because I was in the habit of putting Durafat, not a bond, because I wanted to still have more fluoride release. And I just like Durafat. The Durafat was basically just, to kick off the remineralization process if there was going to be some ongoing transference through the GIC. And so that was fine. Now, he was as happy as anything. That colouring, that discolouring, that didn't bother the family at all. They knew that there would be some discoloration. This was actually way better than what they were expecting. But the fact is that he was able to eat and drink and function really, really well. Seen him for 12 months past this visit. The GIC has not broken down at all. It is not worn away at the edges. It has remained totally intact, certainly hasn't broken down, and we're now up to the 18-month mark with that tooth being fine. About 6 months ago, so it was like 12 months after the first application, he came in, and the tooth was a little bit sensitive. We figured out it was this bit here that had regained some sensitivity. So all I did is I put silver fluoride over the whole part of that tooth, silver fluoride, stannous fluoride, and Durafat, popped that on there. The whole thing went really black, and but only until it all cleaned off. But desensitized again. And I said to him, buddy, you know, I'm happy to keep doing this. If this is all it takes for you to keep this teeth till it gets to the point where it's kind of saturated and it's not going to be sensitive anymore, you just come in and say, Kath, I need some more of that stuff on. He thinks it's the greatest thing out. Now, eventually that tooth will probably, you know, it'll maybe get crowned. They don't want to go down the orthodontic route. Okay, so that tooth they know will be high maintenance, but it's not sensitive, so it's okay. And it certainly hasn't had any post-eruptive breakdown. He is so proud of this particular tooth and he knows that I show it everywhere, that he's actually a student at my son's, where my son is a teacher, and he's always, you know, saying, where's my tooth at now? Where are we off to? And, you know, I can say, oh, we've, you know, gone to Darwin, or we've, you know, been here, or, you know, we're going, you know, we went to New Zealand last week. And he thinks it's great. So his attitude is really good. But the thing is, that's only come about because he got so much relief. I'm just going to go and show you one more case history, and then I'll open it up and we can have some discussion if you like. So this next one was a highly anxious girl, really, really anxious. She came to me after she had seen another dentist in the practice where I was working, and the dentist had then moved away, and so I got handed over her treatment plan. She was so anxious. She didn't want a local anaesthetic because the 2-6 had been restored with a local anaesthetic previously, and it had not had, I don't believe it had had a deep anaesthesia. The filling was really good. It had a composite resin in it, and it was a beautiful looking filling. But what she was worried about is the fact that she had a 1-6 that also needed to be restored, and she was absolutely flipping out. All of her 6s were sensitive to eating and cleaning, but to a different degree. And what I thought was very interesting from a myofunctional point of view, she was only eating everything in her anterior regions to avoid anything going down to the back. So that's not good. It's certainly what we don't want for a developing child and a developing jaw. And it was interesting to see that the kids actually they change the way they actually, you know, eat or drink or some of their foods to cope with the fact that they've got these highly sensitive teeth. Okay, so what we did on her first visit is we were able to put some CSDS on these teeth. So this here is the 3-6 and 4-6. They were sensitive to air, but they were okay. So I was able to pump a bit of air on those ones, and I put the CSDS on, you know, just the 3-minute stannous fluoride, silver fluoride, and then the stannous fluoride. And when they came back 2 weeks later, this is what they look like. So you can actually see here that some of that dark area, this is where it was either remineralized or a little bit demineralized, sorry, or a little bit caries. And so, but they were totally desensitized. And incidentally, those teeth become desensitized the day of application. It doesn't take a while, it's completely blocked off. And then what we ended up doing is we put an Equiafort sealant, protective sealant on those. And I've been following those ones up now for a couple of years as well. They have not moved, they've not broken down, they've not been lost. Equia is tough, and it adheres really well when you've gone through and done this a second. You don't do it at the same day, and you can put a dentine conditioner on there then to properly prepare the tooth. And then I just left all of this area here, I just left that and covered that over. I was quite confident that that was going to be not going to progress any further. Okay, but then the 1-6 was quite a problem, because this is what we had, and there was no way I could actually get any air on that tooth whatsoever. So I did the same thing, I just dried it with a cotton pellet, and I put the CSDS on. So when she came back the following week, you can see here, this is this is parts of a GIC that had been placed over that tooth and had come away in the past. So we did this, and like the parents knew that this was not going to look pretty, but they also knew that it was going to help with the sensitivity, because that had been, you know, we had proved it on the first time. So they were more than happy then to have a second application done. And you can see again, it came back darker and really was indicative of how faulty the enamel on that tooth was. So that was what we found after the second application. But at that application, okay, there was no sensitivity at all on that tooth. So I was able then to, I did do a little, like a slow speed round burr. I just cleaned out some of this dark stuff down here, which of course it was a bit crusty and a bit burnt toast, a bit loose. So I cleaned that off. We put this GIC all over there as a protectant again. And then at the 2-month review, this is what we've seen. And I have been following her up, and I've got other photographs, and that has not broken down. And the tooth has remained totally desensitized. Now, so she was really happy with all of those, because they were the major problem ones. But once they had been taken care of, the tooth that then became sensitive was the one that had the big restoration on there, and that's this tooth here. So she had this, you know, full-on restoration all over this tooth, but it was still sensitive, and that was the one then that was giving her problems. And I didn't want to take out the filling, okay, that would have been crazy, because you would need LA for that. I didn't know what else to do. It was early days, and I just said, let's just put silver fluoride all over this tooth. We went right over the filling, we went right over all the peripheries, right down around the sides, put the silver fluoride, stannous fluoride on that, and guess what? It took care of the sensitivity. Okay, so this is actually how much we covered it. So we used it there as a detector, basically, and a desensitizer. And we actually then repeated that again in the late November, because this was August that we did this. We did another application late November. But this is where her sensitivity was coming from. Once we had taken care of, you know, everything else, then we were able to determine that this was the area that was still giving her sensitivity. That was then in the January. She came down to it. She then presented with a shift score of 2. Now, if you know anything about a shift score, it's a sensitivity score. 2 is where it starts at 0, you have a hypomineralized tooth, no sensitivity at all. You can puff air on it. 1, you can puff a little tiny bit of air and they sort of go, oh yeah, that's a bit. 2, they think, oh no, I don't really like that. And 3 is that they buck right away. Okay, so they're the levels. So she came back then with a score of 2. So again, we just reapplied the CSDS over that. And for floods, so 4 months later, she came back and there was much less sensitivity. And then we tidied things up a little bit, and she's not had any problems with that since. She's eating on both sides. She can say, hey, you know, Mum, she said to be reported, I can eat, you know, hot and cold things and it doesn't hurt, and I can eat on both sides. And I always make sure that the hypomineralized patients, or the kids with hypomineralized teeth, once you have restored or fixed their sensitivity, I make sure from experience now that they actually are eating on those teeth, because oftentimes they are so protective that they don't think to go back and eat on that side. They're always been eating on one side to protect this side. They don't think that they're able to swap over. So if you're ever working with the hypomineralized kids and you're doing something like this, make sure that you tell them it's okay to eat on both sides, because they might just get a bit protected. Okay, so let's open it up for questions there, if you like, and fire away.
Kath, it's Kate here. I was
Okay.
just going to say, how are you? Just going to say that that's really good that they accepted the colour of the tooth. That's obviously something that, you know, would have been my concern.
Okay. The reason why they accept the colour is because it is a payoff for the kid having no sensitivity. And I show them, I've got, you know, the armor approach that I use, and I've got the pictures now. Actually, those two patients are featured on the hypomineralized chairside assistant. They're the two cases that are on there. What I like to do is I show them what it's going to look like. And they go, yeah, that looks fine. But because the kids are so relieved that they can eat anything, that they, you know, by the end of that day, they're having ice cream on that tooth. It's incredible the difference it makes. And so the payoff of the discoloration, they say, oh, it's at the back. Nobody's going to see that. It's really, I think we get more hung up on that as clinicians, but you certainly have to explain that to them. And sometimes the alternative, if that was a stainless steel crown, they actually don't like that as much as having a GIC and some darkening around there. And when you've got a GIC that can stick in there, now those teeth are going to have to be managed for sure. And I'm not, you know, and some they might have to eventually be, you know, extracted for ortho, but not everybody is going to want to go down that path, and not everybody can afford to go down that path. And so it's kind of you've really got to think of everybody's, you've got to give them all the options, and they certainly get the options. And sometimes they go to the orthodontist and they just decide they don't, you know, they don't want to do that. But we've got something that we can offer them, at least they're functioning properly.
That's great, Kath. Thank you.
That's okay. Has anyone else got any questions? Can you see now why I really like that picture of Jeremy Horst, so that you can explain to people how it works, when you can see, you know, those little threads of silver blocking up the tubules, and actually, yeah. Back in a long time ago, we used to use stannous fluoride when we didn't have any of the other fancy fluorides. Back in the 80s, our normal fluoride treatment was the stannous fluoride treatment just alone. We didn't have the level of sensitivity that we're finding in the hypermineralized teeth these days. And I think that may have been because we were using a metal fluoride on those teeth as well. So,
Kathy, it's Claire.
Hi, Claire.
Hi. I just wanted to know, you obviously select the teeth that you're going to treat with silver fluoride. You don't treat those that are, you know, severely affected.
I do.
And have you had any that
I do.
blown up? You
Sorry?
do treat them that are,
when they've got post-eruptive. Yeah.
have you had any blow up?
No, I haven't. Okay. No, because the thing is, I've treated some with significant post-eruptive breakdown, and that have had very deep lesions, and we've been able to arrest the process of the caries that was starting, and then get the teeth filled. Do you want me to find you one, and I'll show you? Because
I'm from the old school, been doing it a while, and we used to find that some of the silver fluoride ones we used to blow up. They'd come back in, you know, a couple of months, and, you know, possibly sometimes some of them had to have the tooth out. So I'm just wondering if that's...
You mean of the 6-year-old molars? Yeah. No, I haven't found that. I guess the thing is, I get as soon as I can. I mean, I've had them go for a long time until they come back. But I've got X-rays and nothing is happening in the down in the root, you know, down in the nerve of the tooth. Yeah, I think, I guess the thing is, back in the olden days when I was using it before, we weren't leaving it on for 3 minutes. We were putting it on and putting a bit of stannous over there, and just putting the what do you call it, the stone adhesive wafer on there.
Stone adhesive wafer, yeah.
Yeah, but we actually weren't deliberately leaving that there for 3 minutes. And I think that is the difference. I mean, the material would have been there, but now I leave that on there for 3 minutes, and then we put the stannous on, and then I put the Durafat. And I think the Durafat is also really helpful in that remineralization. So yeah, I haven't had any blow up at all. So and I've had one that was really, I haven't got time to find it now because I've just been given a warning from Zoom. But yeah, so yeah, you know, in the presentations that I do, I've got, you know, 4 or 5 cases, and they're quite astounding. Has anyone used silver fluorides on hypomineralized teeth yet?
Not me, not yet.
Mm-hmm.
Me?
Not yet.
Okay.
Me, Christine here.
Christine, yep.
I'm yet to bring him back, but he had 4 really, really yucky teeth, and this COVID thing came along, and I couldn't do much else with them. So I said, let's put this on and see how we go.
It'll be
so I'm bringing back.
Follow. Yeah, be interesting to follow that up. And were you using CSDS for that one?
Yeah. Yeah.
Mm-hmm.
So I'll send you pickies. Yeah,
definitely. I had some pictures sent to me today from somebody who did an extremely deep 8.5 or 7.5 on a 3-year-old, and you would normally have looked at that tooth and said, "Oh my gosh, no, it's not going to work," and it did. So now it goes on to the stainless steel crown side of things. So yeah, so it's a challenging concept to use this, but yeah, it's been something that has, you know, what it has done is it's changed the way I've been able to deliver really good treatment to these kids, because otherwise, if you can't get good anesthesia, they're in pain while you're doing it. It's so traumatic for the practitioner as well. I don't know how anyone else feels about that, but I certainly have. All right, well, what I'm going to do is I'm going to finish this here. If you've got questions that you have any that you want to, or comments that you want to say, or you want to answer anything, just email me at or message me through the group, the Facebook group. I don't mind answering questions, but I just sort of think that the hypomineralized one is something that is going to gain some traction because of the desensitization. And just do a couple, like you did, Christine, do a couple, see how you go, and then you'll build a little bit of confidence. And then at least you're doing something before they go off to the orthodontist, or they go off to, you know, whatever else you're going to do, to GA or whatever. I prefer them to be treated really simply, and then they have time to make decisions. Okay, well, nice to see you all. We will talk to you again next week. Is anyone interested to keep on trying to do this over the next few weeks until we all get back up to scratch?
Yes, please.
Yes, please.
Still keen. Okay.
Yes, thanks. Yep.
Okay, that's fine, because I'll do it as long as the demand is there. Okay, and I might even, I'll see if I can get a guest thing coming on. Okay, all right, I've got to go because we're getting the flash. Okay, bye.
Thanks, Kathy.
Thanks, Kath.
Bye.
Bye.
Kathy.